few disclosures from me. So, and I have to say I really enjoyed Kirsten's talk and Liz's talk. They both touched on themes that are common to all of us as healthcare providers, and I also have to mention that I give a monthly amount to MSF on a regular basis because I really admire the work that they do, and I myself can't be out there doing that work for my own reasons, so I give money to support them. I think they're a really excellent organisation. So we live in an ageing society. 82% of the population is aged over 15, and the median age of the population is 37, and you can see the two population pyramids there. This one shows a typical developing country where the bulk of the population is in the younger age groups and very few in the older, and here you see these bulging sides in a population like Australia. That's actually Japan, but the Australian population pyramid looks like this, and an extremely aged population will look like that. So this is Australia 2014. Looks similar to the Japanese, not quite as bad as Japan, but we're getting there. 15% of the population at the moment is over 65, and it's expected that almost a quarter of the population will be over 65 by 2064. The number of people aged 85 years and older will increase from 300,000 to 1.9 million in Australia by 2064, and there's quite a high chance of being in a nursing home, particularly if you are over 85. And about 10% of hospitalised elderly have a respiratory infection. Now, we all know that acute care consumes most of the healthcare budget. For those of us in primary care and public health, we're quite well aware of this. And ageing of the population and the increased burden on acute health services then increases the drivers for primary prevention and positive ageing. And immunisation is part of positive ageing. Interestingly, the government has also been looking at making the age of retirement older because you can see from this graph the workforce is ageing. So the proportion of people in older age groups that comprise our workforce and our economy has been growing over the decades. So the proportion of Australian public service employees who are 50 years of age and over has grown significantly, increasing from 20% in 2001 to 31% in June. So keeping seniors healthy makes economic sense, not just because we can prevent hospital admissions, but because we'll increasingly rely on an older workforce to sustain our economy. There will be older age of retirement, and it just makes it really important that we utilise all opportunities for prevention as a means of positive ageing. This is the coalition plan in 2011 to raise the age of retirement to 70. So positive ageing, vaccination is just really low-hanging fruit, and I'm sure you're all advocates of vaccination. I understand there are immunisation nurses here. We know it's safe and effective. Influenza and pneumococcal vaccines and now Herpes Zoster vaccine are funded for the elderly. Vaccination rates yet for adult vaccinations that are funded are much lower than the rates in infants. So infant vaccination for funded vaccines is over 90%. We get over 90% uptake. But for adults, it's between 50 and 70%. So there's this huge gap. And why is that? And I think it's because doctors, nurses and other providers are not as convinced about vaccines for the elderly as they are for vaccines in infants. And there's a whole lot of research that shows that the most important predictor of vaccination is doctor recommendation. So even a hesitant parent will vaccinate if their doctor recommends it. So why is it that doctors don't believe in vaccination for the elderly? I think nurses are more likely to advocate for vaccination than doctors from the research. Population surveys have been done, a whole range of them. The latest survey in 2009 showed that about 75% of people over 65 were vaccinated against influenza and only 54% against pneumococcal disease. And a survey earlier this year found that two-thirds of people aged 65 to 69 were not vaccinated against pneumococcal disease and 30% not vaccinated against influenza. There's generally a low awareness of the availability and recommendations of vaccines among older adults, and a survey performed in 2015 found that only 2% of 60 to 80-year-olds were aware of the availability of the herpes zoster vaccine. And according to this survey, only 4% had been immunised against shingles, despite the fact it's recommended for everyone over 60. And only 17% thought they were at risk of flu, and 9% thought they were at risk of pneumonia and shingles. 9 and 7%. There's our adult vaccination schedule on the NIP. The latest change has been the addition of shingles for people over 65. It's funded for 70 to 79, and that's being rolled out this year. So a single dose of zoster vaccine is recommended for all adults over 60 years, and it'll be provided free for 70 to 79-year-olds from November. And there'll be a 5-year catch-up program for people aged 71 to 79. And we've also got tetanus and pertussis at 50. So the thing about adult vaccination is, unlike infants, where the mum or the dad brings the baby in to get them vaccinated, adults are a mobile population. There's no easy access point. They're difficult to target. And elderly may have multiple providers. At the moment, there's a lack of a universal health record or vaccination register, though we have one coming. But when that will actually include older adults, I don't know. At the moment, it's only going to go up to the age of 19, the new immunisation register. There are provider barriers, so lack of confidence in vaccines by healthcare providers. And there's also less immunogenicity of vaccines in the elderly, that's a fact. And we have a paediatric immunisation culture, because immunisation has arisen from paediatrics as a discipline. So it's predominantly, the experts in immunisation are paediatricians, so there's far fewer champions for elderly vaccination. Peak advisory bodies are well represented in paediatrics, they're less represented in adult medicine, and yet adults are the majority of our population. There's many missed opportunities for vaccinating seniors. And there's this myth, pneumonia is the old man's friend. That picture there is just, one of the great resources that we get on infant vaccination, but we don't have as many resources like this for elderly vaccination. So let's talk about pneumonia being the old man's friend. We've done research that shows that if you are demented, you are less likely to be vaccinated than someone who is non-demented. If you're over 80 years of age, you're less likely to be vaccinated than if you're under 80. Nursing home residents and staff are less likely to be vaccinated. And yet, we see recurrent explosive outbreaks of flu, pneumonia, other infectious diseases in nursing homes, which affect both residents and staff. And usually, when residents of aged care facilities become sick, they get sent to hospital for treatment. So how is pneumonia anyone's friend? Communicable diseases impact more than just the individual. They are transmissible to other people. There's individual suffering. You've probably all seen someone suffering with pneumonia. Why would you want someone to suffer like that? Aged care facilities often have to be closed down during outbreaks. So there's a major economic impact. And you recurrently see people who are not vaccinated, they have had vaccination withheld, but they're admitted to hospital when they get pneumonia. The other interesting thing, I think, is about delirium. Elderly people can become delirious because of an acute infection, such as a UTI or pneumonia, and then they have loss of autonomy and mental capacity, and decisions and judgments get made when they're in this vulnerable state. And the elderly are very vulnerable during acute illness. Acute infections, in fact, are the most common cause of delirium in seniors, and sometimes you actually see not for resuscitation decisions made while people are delirious in a reversible condition, people who've been independent living. And there's also been research done that seniors who might say, I don't want to be resuscitated, actually change their mind when they're actually ill. So how they feel when they're well is different to how they feel when they're ill. But in that situation, then seniors might lose autonomy to their children or to their doctors who make decisions on their behalf. And doctors do make value judgments about the value of prevention and fail to recommend vaccines. So nurses have a role to advocate. I think, in my observation, nurses are stronger advocates than doctors for patients. And I think those of you working in primary care can take on that role to really advocate for vaccination. So to me, pneumonia is the old man's friend translates as older people are a burden and should just hurry up and die. That older people have no right to self-determination or autonomy. That older people have no right to prevention or treatment, nor to a healthy life. There is ageism in healthcare, and there are value judgments that we all make in healthcare, and there's been research to show this. There are ethical issues about withholding treatment and prevention, and ethical issues around withholding information, about not telling someone there is a vaccine that is free of charge for them because you think, they're not worthy of prevention. In fact, some of the research, when you ask elderly people why they didn't get vaccinated, the most common reason is, my doctor never told me. So let's talk a bit about immunosenescence, which is a fact. Basically when we reach the age of 50, our immune system progressively fails. It fails exponentially, not in a linear way, exponentially. And there's a wide range of defects in cellular and humoral immunity as we get older, and this makes vaccines less effective in the elderly. That just shows the relationship of cell-mediated immunity to varicella zoster virus responses, and you can see an exponential decline. So there is a need for research to focus on improving vaccine immunogenicity in the elderly, and there's many techniques that can do this. We shouldn't just assume that frail elderly patients can't respond to vaccines. And I'll just touch on some of the research studies. For example, high-dose inactivated influenza vaccine can elicit a better response in older patients than standard dose vaccines. There is a new inactivated herpes zoster vaccine that's demonstrated over 97% efficacy in adults 50 to 70 and above. So that kind of challenges the idea that you can't get high efficacy in older people. Intradermal administration is also a method that's used with some influenza vaccines, for example, and there's a range of other delivery techniques that improve the immunogenicity, such as using the microneedle patches and so on. This is a study that we did which looked at the functional antibodies to pneumococcus, vaccinating with the polysaccharide and the conjugate vaccines, the Prevnar and the Pneumovax, and the red shows people who had low antibodies to begin with, and the blue shows people who had baseline antibodies that were okay. And you can see that the people with no antibodies who look pretty poor in their responses, they actually mount a pretty good response. The red line goes up. So that's telling you that older people, even if they've got low baseline antibodies, can still mount a good response. Let's just talk a little bit about immunology. So in infants, the thymus is what produces T cells. It doesn't develop fully until 6 months of age. And until then, babies are much more vulnerable to infection, and they rely on maternal antibodies and vaccines for protection. The infant immune system matures with age. So each dose of vaccine that you're giving on the background of progressive strengthening of the immune system is a winning game. There's big rewards in infant immunisation. But many vaccines display waning of immunity over time, even in healthy people. So there's even now evidence emerging that measles vaccine, for example, does show long-term waning of immunity. Waning matters a lot if you've got 80 years of life ahead of you, but probably doesn't matter as much if you've only got 10 years ahead of you. So the opposite's true about the elderly. Each vaccine is given on the background of a progressively failing immune system. It's a losing game. It's not as rewarding. But this isn't a reason to deny vaccination to the elderly. It's just a challenge that requires innovative solutions and a change in perspective. Yes, vaccines wane in the elderly, but it doesn't matter if they haven't got 80 years of life ahead of them as an infant does. So the other thing is about vaccine efficacy. So vaccines in children are often over 90% efficacious. So in vaccinology, people think of a vaccine as pretty bad if it's less than 80% and terrible if it's less than 60%. But I don't think it's an appropriate comparison to compare elderly vaccine efficacy with pediatric vaccine efficacy. What we should be thinking about is other things we use for prevention in public health. So 30 years ago, having a myocardial infarction led to a reduced life expectancy, and that is not the case anymore. Today, mainly through innovations in improving the time from onset of chest pain to revascularization, has led to dramatic improvement in survival. And you never hear of ischemic heart disease referred to as the old man's friend, do you? Statins now, which we accept as worthy prevention, have an efficacy of about 25% in preventing ischemic myocardial infarction. So why are we worried about a vaccine that's got 50% efficacy or 60% efficacy? So I think in public health, when you look at all the other interventions we use, whether it's antihypertensive medication, smoking cessation, etc., the efficacy is in the order of 25% or less. So vaccines actually in the elderly look pretty good when stacked up against other preventive measures that we use. And efficacy is not the full story. It's only part of the equation in public health. You've got to also think about burden of disease. So public health benefit equals burden of disease times preventive efficacy. There's burden of disease for influenza. You can see big peaks in the infants and in the elderly, and it's the leading cause of death from an infection worldwide. Pneumococcal disease, again, the biggest peaks of disease are actually in the elderly. It's age on the x-axis. Tetanus. Tetanus is also a disease that we see in the elderly predominantly. Pertussis. Now the bulk of pertussis burden of disease is actually in adults, and it's shifting to older and older age groups. Nearly 30% of mothers have a grandparent providing childcare for their children, and about 35% of children receive grandparent care. So it matters, that your elderly are protected. But that's not the only risk. We're actually now seeing documented deaths from pertussis in elderly people. There's been at least 7 in the last several years, and nursing home outbreaks of pertussis are increasingly documented. So it's not just a risk to the infants that are being cared for by older grandparents, it's also a risk to them. I'll skip over that. This now shows you the epidemiology of herpes zoster and postpaid neuralgia, which is the inverse of the curve we saw on the waning immunity. You can see the increase in risk of herpes zoster and postpaid neuralgia is exponential, and the rise starts at the age of 50. So when you're 50, your immune system is starting to fail, and this conversely starts to increase. So there's also other evidence that vaccines might have other benefits, and there's a real intersection of chronic diseases and infectious diseases. For example, there's a lot of evidence now that influenza vaccine might protect against myocardial infarction. We did a study where we found 10% of AMI patients had undiagnosed flu at the time of AMI. The theory is that someone who's got an atherosclerotic plaque in their coronary arteries, but it's not critically stenosed, so they don't have symptoms, they may never get symptoms. If they get flu, there's cytokine response, you get inflammation, a thrombogenic state, and formation of an acute clot in the coronary artery that blocks it off completely, and that triggers a heart attack. And there's been clinical trials as well that have shown that flu vaccine reduces the risk. So public health benefit is the burden of disease times preventive efficacy. So let's just do a little experiment here where we look at burden of disease. And I'm taking some data here from on pneumococcal disease in Australia. And I've just made this table. Age groups from the youngest to the oldest, number of cases of invasive pneumococcal disease, vaccine efficacy, just theoretical vaccine efficacy, cases prevented. So if you're vaccinating kids 0 to 4 and you've got 95% vaccine efficacy, you're preventing 47 cases. If you're vaccinating people over 65 and the efficacy is 30%, you're preventing 64 cases. Okay, so the burden of disease matters. If the burden of disease is really high, even a vaccine with low efficacy still has public health benefit. So just to finish off, some of the other barriers in elderly vaccination is that providers are very heterogeneous. GPs are more likely to support elderly vaccination than hospital healthcare workers, including nurses in hospitals, who are quite different in their perceptions to primary care nurses. And hospital healthcare workers are significantly less likely than GPs to know how to access information about vaccination. We do have a whole-of-life register coming, but when it will actually capture adults, we don't know yet, but it's great news that this is coming, and this is a major step forward to enable uptake of vaccination in adults. As I said, doctor recommendation predicts vaccination even in people with negative perceptions of vaccination. The other problem is the evidence base. So most RCTs of vaccines, even vaccines for older people, will systematically exclude very frail elderly people from their recruitment criteria. And yet this is the largest growing area of healthcare need, but the smallest body of evidence. And it's a vicious cycle of lack of evidence, lack of recommendation, lack of protection. One of the reasons why herpes zoster vaccine is only recommended from 70 to 79 is because the numbers of patients in that clinical trial was really low after the age of 80, right? So there's no evidence, no recommendation. The other issue about frail elderly and why they're excluded from trials is they've usually got multiple medical conditions, they're on many different drugs, they might be demented, have decreased cognition, high mortality, high attrition, low mobility, difficulty attending follow-up appointments, altered body mass index, etc. So we need more clinical trials in frail elderly, we need more cost-effectiveness analyses on elderly vaccination, more research to improve immune response in the elderly, and a recognition that ageing is the single largest area of healthcare need in Australia. And I think we need a change in perception on the value of preventing illness towards the end of life. A whole-of-life register will make a big difference, I believe, but no single measure alone is enough. However, public funding of programs does have a big impact on uptake of vaccination. I'll skip this one. What will it take to improve vaccination uptake? So for vaccination programs where it's not funded for everyone in the age group, say for example people under 65 for flu vaccine, if you've got heart disease, lung disease, etc. Generally research has shown that any kind of targeted recommendation, you can't get uptake more than about 30%. It's really hard. Financial incentives, we use them in paediatrics. You all know about the no jab, no pay policy. They're not tested in adults. Public funding of a program does have a big impact, but we still have a gap between adults and infants. Education programs do work, but they've got a transient effect. You've got to keep on doing it to keep people vaccinating. So I think maybe a quantum change in health provider perspectives. I think allowing pharmacists to vaccinate is probably a good thing, and I'm in the minority, I think, in the immunisation medical side of things, thinking that, but I think it improves the accessibility. And I think that, so there's many arguments around healthy ageing from an economic perspective, an ethical perspective, a social and a human rights perspective. We should advocate for equity in disease prevention. Senior citizens have a right to autonomy, to self-determination, and to make informed choices about vaccination. They can't make those choices unless they're given the information. And I think, everyone has an equal right to available vaccines for disease prevention. We need to acknowledge and reflect on ageism and value judgments in healthcare, and we need a paradigm shift. So, my rules on vaccinology in the elderly, the glass is half full, it's not half empty. Pneumonia is no one's friend. Seniors have a higher burden of disease and more serious complications. Infections are unique because preventing one infection prevents transmission to others. A vaccine can't protect against something it's not designed to protect against. So people often talk about the pneumococcal vaccine as, but it doesn't protect against all-cause pneumonia. Well, why would you expect it to prevent against Hib pneumonia or viral pneumonia? Vaccine waning doesn't matter as much in the elderly. And vaccines with low efficacy have public health impact if the disease burden is high. Vaccines are more effective in the elderly than many accepted preventive measures that we use in public health. Thank you.
Thank you.